Welcome, sir.
We're going live. 5, 4, 3, 1. We are live.
Right. So I welcome all the participants for this webinar on knee preservation. And today we'll be discussing techniques of medial open wedge high tibial osteotomy. And we have Dr. Mangal, Parihar, and myself for just let me share the media. अरे दूसरा है यार. ये नहीं. Just 1 second.
What's the problem, sir?
Just 1 second. I have been able to
Screen
stop.
share नहीं हो पा रही है.
हाँ, अब बस अभी करता हूँ. I think I'm there. Just 1 second. सभी को अपन- Sorry, I think, am I visible?
Yes, sir.
And my screen is seen.
Screen is also visible.
Right. So we will discuss the techniques of medial open wedge high tibial osteotomy. And for this fifth webinar, we have Dr. Mangal Parihar with me for this. And we'll be discussing a fixator assisted medial open wedge high tibial osteotomy, how and why. And then I'll be talking on medial open wedge high tibial osteotomy with angle stable implant, followed by a panel discussion. As we are aware, the magnitude of the problem of osteoarthritis is quite high. We have around 46 million patients, and we have the need to sit cross-legged and squat on the floor for activity of daily living and for social culture reasons. And we must remember that we have a health budget which places only on the 45th out of 94, which was reviewed by this group. What is important is that we have to have the knowledge and the attitude to conserve knee and then we should have the skills. So with these webinars, we are trying to gain knowledge and change our attitude that we believe knee preservation is possible. And then in pre-conference workshop on 13th December, we have 1 day for the hands-on workshop and other discussions. The objective of the treatment to conserve knee is we have to understand role of lifestyle modification, weight control and exercises. And we have also learned about the success story of HTO. And we must remind ourselves that total knee replacement is internal amputation of knee. And a word of caution, now industry is trying to propagate that UK is a knee preservation surgery, in fact, which it is not. And we must also understand there's a difference between OWHTO and HTO, and they are not synonymous. So with this, we'll have two lectures, one by Dr. Mangal and the other by me. And before we proceed, we must have a full-length X-ray with patella facing front. We must do the malalignment test and see whether there's a varus deformity. And then we should draw the mechanical lateral distal femoral angle and medial proximal tibial angle. And if the MPTA is less than 87 and medial LDFA is more, then we will have to have this procedure. And most of the time, because of tibia vera, the MPTA is less, which requires correcting by an open wedge high tibial osteotomy. And then we measure what is the angle of correction which is required, and we transfer this from the pora onto the medial side to decide what is the wedge which is required to open. Then we have the panel discussion and question answer session, and we have Dr. Mangal Parihar for the first part of the talk, who's advisor of IOA knee preservation subcommittee. His special interest in external fixation, infection control, complex fractures, non-union, and osteotomy solution for OA. He is also interested in teaching methods and faculty training and enhancement. I am there as the chairman of the knee preservation subcommittee this year, and I have the pleasure of attending knee surgery fellowship at Luzerne, from where the open medial wedge osteotomy has progressed and gone around the world. Then we have Dr. Milind Chaudhary, who is the director of Center for Rizaro Technique at Akola, and he is the most experienced person for TCBO in the country. And we have Professor Ravi Mittal from All India Institute. He has also interest in knee conservation, and he is one person in institute who's most sought after for conserving the knee joint. Then we have Dr. Dinesh Thakkar, who is member of IOA knee preservation subcommittee, and incidentally, he is also the joint secretary of the IOA this year. Then we have Dr. Ajit Saigal, who is also the panelist. He is general secretary for SARC Orthopedic Association and has a lot of interest in knee conservation, and he has also made one trade for the same procedure. Now, I'll request Dr. Ram Chadha if he has joined us. Otherwise, I'll request Dr. Thakkar to give us a few words of wisdom. Over to Dr. Thakkar.
Dr. Ram Chadha is not joined.
I think so. He said he'd be joining, and Navin also said that he could be joining, but you are the boss now.
As we all know that our association, Indian Orthopedic Association, is basically an association for the academics, and amongst the all academic activities, this knee preservation subcommittee has organized today's webinar on open wedge high tibial osteotomy, and Dr. Sanjai Rastogi is a chairperson of the knee preservation subcommittee. I appreciate his all efforts during the whole year. There are so many webinars has been organized, and we are also trying to organize the physical meetings also. And we all, I don't think any orthopedic surgeon is not aware about Dr. Mangal Parihar. It's head of all the knee preservation subcommittee, because he is the senior most. He is a devoted for the knee preservation. And Dr. Milind Chaudhary, he is also a person who is very senior and have aptitude to preserve the knee. So today's topic on open wedge will be very interesting for all of us, because two senior people, most experienced people in their fields, will deliver the talk, and we will enjoy the talk. Thank you very much to all.
Thank you, Dr. Thakkar, for your kind words. Now I request Dr. Mangal Parihar to tell us Fixator assisted ITV osteotomy, why and how.
Okay. Thanks for the kind introduction, Sanjay and Dinesh. So I think there is quite a lot of knowledge already in terms of open wedge. And I want to devote my 20 minutes to kind of underline why I still continue to use a fixator. I started using a fixator before Tomofix, which is a very reliable method of fixation, was available. Initially Ilizarov, and then this unilateral fixator, which I'll come to in a bit. And I want to sort of underline the reasons why I still find that the fixator is very, very useful in my hands. So here's a 66-year-old female who had pain since 3 years, unable to walk, significant varus. And this was her x-rays on presentation. So bottom line, age, amount of damage, really these are not criteria for excluding patients from an HTO, as long as the lateral cartilage is okay. So if you look at her walk now, she has significant lateral thrust. Every time she puts weight on the leg, the knee goes, externally. And this kind of patient will benefit by a high tibial osteotomy. I point out the lateral thrust over here because oftentimes this is an indicator that there is a femoral varus also. And just because this patient is 66 years old, it's not necessary that they should go into a knee replacement. You could think about an open wedge or a closing wedge, whether you want to do a fixator or a Tomofix. And there is a little bit of controversy whether you should do the tibia or the tibia and the femur. In this particular situation, I think you should do the tibia as well as the femur. So I decide this based on the MRI, which shows me whether the lateral cartilage is okay, valgus stress view, which opens up on the medial side, and if the patient is an active person or otherwise a poor candidate for a knee replacement, I will certainly go for a realignment kind of surgery. So that's her valgus stress view, which shows that the medial side opens up. And this is the planning that we've done. As I said, because her LDFA was abnormal, 94 degrees, therefore, if I have to correct all of that in the tibia with an opening wedge, it becomes whatever I need to correct in the tibia plus an additional, probably looks like 7.5 mm correction to compensate for the femur. So therefore, in this situation, I will do an LDFO, DFO, and that I prefer to do it closing wedge, and the HTO I do open wedge. So this is a standard technique now of doing the DFO, where you do a closing wedge with a biplanar component. To that, you can see that vertical component over there, which adds a lot of stability, and the same technique is also used with an open wedge Tomofix. But this adds a lot of stability, prevents rotation. So this is at the end of correcting the femur. You can see that the alignment rod is still medial, and therefore that's the amount of correction that is needed in terms of an HTO. So we do a regular Tomofix in this particular case, where intra-op the alignment rod is around the base of the lateral tibial spine, so that we are unloading the medial side enough. And then if we've done a femoral osteotomy, I use that opportunity to also add whatever wedge was removed from the femur. I will add it in over there, which is not always necessary. I'm sure Sanjay will talk about the standard open wedge where you don't need a graft. Or sometimes when we do a debridement of the knee, we excise osteophytes. Those also can be added to this region. And that's her post-op X-ray with the femur and tibia both osteotomized in one bone. However, when we do the full length post-op standing, I find that there is overcorrection. And this is partly because I will always exert myself to avoid undercorrection. I don't mind going a little overcorrected, but I certainly want to avoid undercorrection. So on table, that was the alignment with all the things that are talked about in the technique, give axial pressure, etc., etc. But in these patients who've got a large JLC, a large opening on the lateral side, that turns out to be a little bit of a problem to judge what is the correct alignment. So we've got post-op overcorrection over here, which is not really a problem in the sense patient is doing absolutely fine. That's 8 months post-op, everything healed off well. That's what she looks like. A good range of motion. And as you will see, her lateral thrust has gone. So patient is quite comfortable in, but you know, if you get excessive valgus, they are not happy with it from the looks point of view and the fact that the knee is kind of pointing inward. This is how we used to do the closing wedge with a Tomofix lateral distal femoral plate. I'm just pointing this out because otherwise there may be a little confusion. That patient was done earlier. Nowadays, what we do is we use a Tomofix medial distal femur plate of the opposite side. This is a anatomic implant. So if and actually it's meant for a medial closing wedge, but if I'm doing a lateral closing wedge of the right side, I will use a plate which is meant for the left and vice versa. And as you can see, this is a very, very low profile implant. So patients don't have trouble from point of view of irritation from the thick lateral distal femoral plate. Now, here's another case. Similar, she didn't require, her femur was okay. Again, valgus stress shows that it opens out. That's the full length X-ray, and that's the miniature way of calculating how to do it. Older patients, I will do a Tomofix. You must remember that the cautery cord is not the same as an alignment rod. And this is the amount of opening that we've done and the alignment that we get with axial pressure, etc., aiming for the lateral tibial spine. So we did an open wedge Tomofix biplanar, like Sanjay will describe to you later. But again, post-op, we have overcorrection. Patient is relieved of her osteoarthritic pain, but she is not terribly happy with the extra valgus which I have given her. So this variability in correction with the Tomofix, especially when you have a large JLC. So this is a picture of the alignment when it is with a little bit of varus stress. And on the right, you see the picture which is with a little bit of valgus stress. You can see how much the alignment changes just by soft tissue change. I've not done any osteotomy as yet. So therefore, what I like to do many of the times is to use an Orthofix, which is a monolateral fixator. There are two pins proximally, which are shown in green. There are two pins distally, which is shown in purple. There's a self-aligning or self adjusting clamp, which is shown in red. And this whole thing is in a T configuration. The upper two pins are kind of transverse and the lower two pins are vertical. And in between the two, there is a device which will allow for distraction. So we put on the fixator on the intact bone, 2 pins above, 2 pins below. And in the extreme right picture, you can see the periosteum through a small incision, which is running along the posterior aspect of the tibia. Once we have the fixator in place, the pins in place, the fixator is removed. And then I do a osteotomy, which is distal to the tuberosity. The tuberosity will come somewhere at tuberosity will come somewhere over here, tuberosity and the attached ligament. So I'm still aiming for the same point that Sanjay will be talking about later, where it is the tip of the fibula. But to me, the importance here is that the distal to tuberosity osteotomy, it does not affect the height of the patella, especially when you have to do a large correction. Also, when you do large corrections, a distal to tuberosity osteotomy does not create any trouble with increased patellofemoral stress or increased patellofemoral pressure. So, though it is distal to the tuberosity, it is still aiming for the tip of the fibula. And this comes from, basic deformity correction principles. Very often, when you draw the proximal axis and the distal axis, where those two axes meet is somewhere around this line, this point, which is more or less in line with the tip of the fibula. If you're doing a closing wedge also, it comes more or less at this line, and that's the reason why a Coventry osteotomy in everybody's hands does well. The issue is with the accuracy in terms of maintaining the correction. And even here, this osteotomy goes in this direction, but the lateral hinge is still intact. So this is where the osteotomy will go. And the difference between what Sanjay is going to talk about and the way I do it, marked in red is the way I do the osteotomy, and marked in blue is the way that the AO Tomofix method is described, where you're going like this, and then in the lateral, there is this biplanar or vertical limb. My osteotomy is entirely below the tuberosity. And doing that, I get an osteotomy which is complete enough that it can be moved like this, but it is also incomplete in the sense that the hinge over here is intact, right? So it's all opening around this intact portion of bone, which is on the at or around the tip of the fibula. So when we do it with a fixator, we are not correcting anything on table. We are just doing the osteotomy, and patient comes out of surgery with the same amount of varus because we've closed it down. You can see that, very little of the osteotomy is visible. And then after 7 days, utilizing the principles of Ilizarov of gradual distraction, we start distracting till such time as you reach the appropriate angle. So here you can see from MPTA, medial proximal tibial angle of less than 90. This has come to a little above 90, and then more valgus depending on what is required. So even when we do it with a fixator, we do all this planned correction. So we find out what is the angle of correction. And from there, we subtract the JLCA that is seen on this X-ray, and we add 3 because that's the normal JLCA. There are 2 or 3 different methods of trying to compensate for this increased JLCA. This is the method that I use. So if you see here, the angle of correction is actually 15.8 degrees. And then from there, I subtract 2.7 degrees, which is this JLCA plus 3. And therefore, I get the angle of correction in finally of 13 degrees. Now, the HKA currently is 170. So to that, if I add 13 degrees, I get into the right range of about 183 degrees. So I'm taking this abnormal JLCA into account. And based on that, we plan with the Tomofix, we say we transpose the angle of correction onto the tibia at that point, and then therefore you will come to know how much you need to open at this gap. Now, same thing if you take it forward a little, this is how much distraction I will need on the fixator to get that appropriate angle of correction at this point. So here, with magnification corrected, etc., that comes to 21 millimeters, which means 21 days of distraction, because with the fixator, we distract 1 mm per day. And of course, you know that the further away you are from the place that is being corrected, you need more distraction to get the same amount of angle. Meaning if my fixator was over here, I would need even more days of distraction. But after 21 days of distraction, when the patient comes back and we do a full length X-ray, we find in this patient that the HK is not 183 or 185 as we planned, but it's almost 190. And the mechanical axis deviation is 65. It's way onto the lateral side. Distraction over here at the gap is only about 17 mm. So we have a spreadsheet to sort of calculate so many days of distraction has resulted in so many days, so much angle, and therefore how much we need to reduce it. So based on that calculation for this patient, we needed 5 days of reversal. That means 5 mm going back to get our mechanical axis deviation at 44 mm, which is based on the width of that particular tibia, and a hip knee ankle angle of about 184. So this is 2 mm. This is not done over days. It is done right then. We do 2 mm, wait for a little while, and then again do it. So this is 2 days of compression. The HKA has now reduced to 187 degrees, and this is 4 days. That means 4 mm of compression. It has now reduced to 85.5. Right now, there are times when you get an HKA which seems appropriate, but the mechanical axis deviation seems a little excessive. And in those times, I will tend to use the HKA as the correct yardstick. So that's just a composite of those same X-rays which you saw. When she started, that was her HKA. When she distracted as per the plan, she was grossly overcorrected. We reduced it, and again, we reduced it so that we got our HKA to the appropriate angle. So her fixator was locked at 185, and therefore, and this is the picture at the end of, maybe after the fixator was removed, you can see all of that has healed because of the gradual distraction and the bone that is formed. But the important thing here is that the net distraction was only 17 days, when as per the plan in terms of Miniachi, etc., this was 21 days or X amount of millimeters. So we really, in this particular situation, if we had only used the plate, again, as per the planning, we would have landed up with over distraction. So in conclusion, for me, the fixator really allows a lot of post-operative fine-tuning in the weight-bearing position. And this to me is even more important. The younger the patient, the more important this is to get that angle just right. Because I certainly don't want to make a mistake in undercorrection, but overcorrection also patients are not very happy. And especially when there is a significant JLCA, that will tend to throw off your calculations a fair bit. I do use the Tomofix in the remaining 20% of the cases, but these are usually older patients, or where the patients, in addition to the correction of varus valgus, they need a slope correction also, because the Tomofix allows us to take care of the slope. With the fixator, you cannot change the slope. And in younger patients, where I am doing it for deformity and not for medial compartment osteoarthritis, because in younger patients, even if you are slightly a couple of degrees undercorrected, it doesn't really make a difference. They are coming to get the limb straight. Whereas in medial compartment osteoarthritis, I think going a little bit, at least on the lateral side, is significant, is important to reduce the chance of undercorrection and recurrence of pain after, let us say, 7, 8, 10 years. So if you get the angle right, I think the literature shows that that has the maximum long-term benefit. So that's why in large majority of my cases, I still prefer to use a fixator for the tibial correction rather than a Tomofix. Thank you.
Thank you very much, Dr. Mangal. Now we'll move to the next part, medial open with high tibial osteotomy. And let me just share my screen. You have stopped your screen.
Yeah, I have stopped.
Yes. My screen is visible.
Visible, scrolling through all the slides.
Right, actually. So now I'll talk on medial open with high tibial osteotomy with the English stable implant, that's Tomofix. And because of the failure of Kudu plate, because of instability, implant failure, slope increase in pseudoarthrosis, and the disadvantage of having external fixator with long wearing time, patient discomfort, pain during distraction, and high rate of pin tract infection. The AO group in their knee preservation section, they developed a Tomofix, which was started in 2000 and finally launched in 2012. The most commonly used was medial plate, which is medial Tomofix, which is used in 85% of the cases, because that's the most common deformity in osteoarthritis knee requiring correction, and it is not site specific. The same plate can be used on medial or lateral side. This Tomofix is a biological internal fixator for metaphysio-diphyseal osteotomy around the knee joint. It is biological because it preserves the blood supply of bone and soft tissue vitality and provides biomechanical stability. It is based on sprinting principles, and that's the reason alternate load bearing and with a functional rehab leads to micro motion and promotes bone healing. This is made of titanium because it's biomechanically and compatible. Now this fixator is a one-stage internal spatial frame which has 4 proximal and 4 distal locking head screws, and it will allow opening up to 22 millimeter. And the reason is the distance between the hole B and D is 3 centimeter, and the plate is put 1 centimeter from the joint line. So when the proximal fragment is 4 centimeters or more, this will have adequate purchase in the proximal part. And the distance between hole D and hole 1 is 26 millimeter. That means if we have a osteotomy gap of 22 millimeters, the purchase in hole D and hole 1 would be perfect. So the initial results of 707 cases were analyzed by AO expert group, and they concluded that the implant offers great potential for correction of both uniplanar and multiplanar deformities. It gave good results in revision surgeries, and this did not depend on the bone graft in the osteotomy gap. The newer generation plate was introduced in 2011, and the same year later, a plate was introduced for Asian population, and biomechanically they were identical. The Asian plate was such that it led to anatomical fit of these small stature patients. And the thickness of this plate is 3 mm. This must be remembered because when you put a locking head screws, they should be perfectly placed to have perfect locking. And these screws are in the proximal part is oriented from anterior medial to posterior lateral. This is not rigid. It is based on bridging principle, and this plate should not be substituted by trauma plate of AO because it is a rigid fixator. Now with the load bearing, there is distribution of forces in a larger area, and this plastic deformation of the plate takes place immediately, which allows micro motion. The hole A, B, C are inclined 10 degrees distally, and the hole D and hole 4 takes spacers, which is they are 3 mm, and these help us to preserve the blood supply. The hole B, A, B, C are aligned convergently to increase the stability and have a spring suspension of the lateral hinge, and the proximal end of the plate should be placed as posterior as possible to have the largest possible locking head screws. The hole in the distal part are arranged staggeringly, so no vertical or shear fissure fracture takes place in the tibia. This plate can be applied by minimal invasive procedure. A wide exposure is not required. By 5 to 6 millimeter oblique incision, it is sufficient to do the osteotomy and correct replace the fixator. And the distal portion is put by making a subcutaneous tunnel, and the screws are locked with a small additional incision. This plate with the fixator is put over the osteotomy gap to provide more stability on the medial side, and it is preserve the periosteum precessinus and medial collateral ligament. When there is an intact hinge, or even when there's a distortion, putting a screw which is distally directed, pulls the distal fragment medially, and the lateral hinge is compressed, and this does not require any placement of plate on the lateral side, as sometimes people think that it is needed. The HORA is a 10 mm lateral bone block, which is just proximal to the tibiofibular joint, and it facilitates highest possible correction, and the compression is achieved by a lag screw in hole 1, the way I have just shown. The implant has a improved osseous primary stability because the plate is placed medially. There is a bone contact behind the tibial tuberosity. On the laterally, the the hinge is already there. Posteriorly, the screws are direct posteriorly, so they support the posterior part, and the proximal prop support is there because of there are 4 locking head screws in the proximal part. So this is the area where there's a bone contact even after the osteotomy because of the biplanar nature of the osteotomy. Tomofix per se is very easy to handle if you understand the implant and the technique. It is user friendly and good reproducibility is there. The first 707 cases were analyzed where the VAS reduced from 4 to 1, and patient was full weight bearing without crutches on an average after 10 weeks. There was no neurological complication, and only 3 patients required TKR because of the progressive degenerative disease and persistent pain. There was only 1 patient who was a narcotic addict who had delayed union, but this also united in 13 months' time, and the implant was removed in 15 months. So the take-home message so far as the Tomofix is concerned, this newer version is Asian specific. It works on bridging principle. A correction of to 22 millimeters is possible. No graft is required, and it can be used even in presence of osteoporosis. Now moving on to the technique, when we do a medial open wedge high table osteotomy, the weight bearing line from medial side is passed on to the lateral side, which is the normal. The cartilage is normal, and the pain disappears, and the medial side heals. And the ideal patient for medial open wedge high table osteotomy is a physically active patient. The physiological age could be any, even 70. The tibia vera, if it's more than 5, proximal tibia vera, then this gives better results. The opposite compartment should be intact. A flexion deformity 20 degrees can be corrected on table by doing this osteotomy. The patient might have certain amount of pain, so he should be tolerant to a VAS of 1. ACL, PCL deficiency is not a contraindication, and obesity and smoking is also not a contraindication, because in presence of this with Tomofix, patient can be operated and good results are achieved. It is only contraindicated when there is loss of lateral meniscus. The cartilage damage on the lateral side is 3.4. There is limited range of motion, or if the flexion deformity is more than 20 degrees. If the soft tissues are in the proximal tibia on the medial side are not good, or if there is systemic and local inflammation. Per se, arthroscopy is not needed. It is only indicated when there is a mechanical issues, because arthroscopy per se leads to deterioration of osteoarthritis knee. This osteotomy is biplanar. The anterior ascending osteotomy is a complete as seen by the smaller saw blade, and the transverse osteotomy is a incomplete osteotomy, which is posteriorly. So this is the patient is operated in a supine position with lateral support and a foot pad, which is allow easy positioning of limb in 90-degree flexion and full extension. The contralateral leg is lowered at the hip. The junction of the convex and the concave point on the medial border is the starting point of osteotomy, and it makes the osteotomy isosceles, which I will show you later. The patient's landmarks are marked with the 90-degree knee flexion with medial joint line, cranial border of pes, medial collateral and tibial velocity. It has been shown by anthropometric distance that the pes incidence is at a distance of 4 to 6 centimeters from the joint line. So this gives an enough area to put the proximal part of the plate. The skin incision has evolved with passage of time. Now we use a midpole incision, which is 5 to 6, just proximal to the pes, and it also avoids damage to the infrapatellar branch of saphenous nerve. The incision runs from a point anterior to insertion of pes in a posterior cranial direction. After the skin incision, the fascia is cleared, and then we raise a tissue-periosteal flap from the sartorius proximal to the osteotomy site, that means pes incidence, which is based laterally, and this helps to cover the osteotomy gap. So this is the flap which is being raised. and this is put under the osteotomy, under the plate to cover the osteotomy. For further exposure, proximal border of pes is identified, and this is retracted through the pes incidence bursa, which is at a distance of 4 to 6 centimeters from the joint line. This is the medial collateral ligament, which is attached posteriorly on tibia. So if it is not raised, there is more opening on the anterior side, leading to increased slope of the tibia. So it is essential to the medial collateral ligament, and for this we retract the pes incidence distally and raise this and CL to avoid knee pain on the medial side later. The osteotomy should be done by a atraumatic technique. The entire sewing procedure should be done slowly with minimal pressure under constant cooling to avoid thermal necrosis, with new blades, because that also helps to decrease the heat. These patients were subjected for MRI. This is a T2 fat suppressed image. On the side of the osteotomy, this is the hematoma seen immediately after the osteotomy, and there is no bone edema seen. That means there is no marrow edema. After 3 weeks, this is the new bone formation, hyperconvolution tissue is seen. That means this is already started healing at 3 months' time and uniting. The size of the hematoma is decreased, and at 6 weeks, there's further increase in the new bone formation, and the hematoma is further reduced. At this time, at 6 weeks, that's what we say, patient can be mobilized without pain with some support. The transverse osteotomy is done from the junction of convex and concave part on the medial side of tibia, and this is directed towards the lateral hinge, and this is the window where it should come. If it is above, then it goes into the joint, which is not correct, and if it's below, it will lead to decreased correction because the fibula is there. The osteotomy should be parallel to the lateral tibial slope, and this is how it is seen. And for this internal navigation of the slope, we pass a K wire in the 1 centimeter distal to the knee joint line in AP direction. And once we see this in a plane, when it is seen as a dot, then we pass 2 wires from the point of concave junction to just proximal to the proximal tibiofibular joint, and the osteotomy is done under it. So this will be parallel to the lateral slope of tibia. So as I said, we pass 1 AP wire 1 centimeter distal to the joint line and 2 wires parallel to the lateral tibial slope. The wires must go right up to the end in the lateral cortex, which should be seen in 30-degree internal rotation, and the osteotomy should be done in one shot to avoid damage to the structures and vascularity of the bone and soft tissue. This is in 30-degree internal rotation. This is the place where the wire should reach outside the tibiofibular joint. The osteotomy will come below it. And this is on the table. This is the AP wire, and these are the 2 transverse wire. This wire, which is 1 centimeter from the joint line, also helps to put the proximal end of the Tomofix in proper place. We hold the 3rd wire outside these 2 wires to know what is the depth of the osteotomy. This is measured, and this is marked on the saw blade. This is the concept of transverse osteotomy, which is an incomplete osteotomy. As you can see in the posterior part, this interior part, the tuberosity is not cut. The protruding wires are cut to have the easy access for osteotomy. Transverse osteotomy should always be done with mean 90-degree flexion. The cutting depth is marked on a new blade, which is 0.9 mm thick, 20 mm wide, and 90 mm long, oscillating saw blade. The osteotomy should be done slowly under constant cooling. We must cut the hard posterior medial tibial cortex first, and the anatomical posterior structure is protected by the movement retractor, which is put anterior to the popliteus muscle to protect the neurovascular bundles. So this is the popliteus muscle, and this is the neuro side of the osteotomy. The retractor and movement retractor is anterior to it. The lateral bony bridge is a hinge. It has micro fractures, and the bone is not elastic. So if micro fractures take place, but if they enter the joint, it leads to instability and decreased impaired bone healing, which it becomes a problem, and it takes more time for it to heal. The posterior cortex should be cut completely, because if it's not cut completely, it leads to plateau fracture or unstable lateral hinge and increase in tibial slope. The ascending osteotomy is parallel to the anterior shin of the tibia at an angle of 110 to 130 degrees from the transverse osteotomy. It should end between the knee joint anteriorly and tuberosity. If the correction is more, we can have this tuberosity as thick as 1/3 of the tibial width. So this is the ascending osteotomy here. It is parallel to the anterior cortex of tibial shaft. The osteotomy planes glide over each other, and this is the area where the healing first takes place. So it should be as long as possible, should not enter to the knee joint or below the tuberosity. So this is the window from where we can have the ascending osteotomy. Ascending osteotomy is a complete osteotomy, and it acts as a wall against dorsal translation of the distal fragment, avoids internal rotation and tendency for the slope to get changed. And this is done with 0.4 mm thick, 15 mm wide, and 50 mm long blade. As I said, it is a complete osteotomy. The cutting is done by keeping the blade perpendicular to the bone and then making it parallel to the ground to cut the anterior portion. After the osteotomy, ruler is used to measure the gap and also to see that the osteotomy is complete. And then we gradually open the osteotomy by passing one and more chisels. The second chisel is passed less than the predecessor, and we can open with a spreading bone chisel to the amount of correction which is needed. The second chisel is passed less than the previous one, and once the desired correction is achieved, we open and see by the cautery method or by alignment rod. But one thing is important, we must make sure that the anterior part of the osteotomy is in contact and they are parallel. Because if they are parallel, there is no change in the slope of the tibia. If there is an inherent unstable osteotomy, one wire each and proximal distal fragment is passed to make sure that there is no rotational malalignment. While opening the osteotomy, simultaneous lateral displacement of the tuberosity takes place with lateralization. For an average 10 mm distalization, there is 3 to 4 mm lateral translation. Then we measure the opening, and then we can fine tune with the spreading chisel by seeing the alignment rod or a pottery from the head of the femur to the ankle joint, and it should pass through the Fujisawa point for the correction. If the osteotomy orientation is not parallel to the lateral tibial slope, this will lead to a change in slope. If the spread is put anteriorly, there is increased slope. If the spread is put posteriorly, there is the decrease in slope. And if the MCL is not released, there will be again more opening anteriorly. So these are the precautions which must be taken. The final correction is seen with full extension on table. The guide wires are removed. The Tomofix is prepared by putting locking head sleeves in hole A, B, and C with the help of a gliding lock. This is important because the plate, as I told you, is only 3 mm thick, and the locking head screw should be perfectly locked. The two spaces are put in hole D and hole 1 to keep the osteotomy plate away, and the distal part of the plate is put by making a tunnel in the center of the tibia distally. And the plate should be put as posterior as possible to have the longest possible screws. And once we are satisfied with the position, the hole D and hole 1 should not overlie the osteotomy gap, and the 1 K wire, 2 mm K wire, it is fixed. Then we insert 2 locking head screws monocortical as long as possible in hole A, C, and B. To compress the osteotomy, the lateral hinge, a locking head screw is a bicortical screw is passed in the neutral position in hole 1, and this is directly in the distal direction. This creates a suspension in the plate and creates an elastic preload, compresses the lateral hinge, and brings the distal fragment close to the plate. So we must make sure that we put it in the neutral position, otherwise the osteotomy gap will reduce. And this should be passed in 10 degrees distally directed, the locking head screw. And then after we are satisfied with the correction, we insert monocortical locking head screws in hole 2 and 3. Then we replace the spacer in hole 4 with a monocortical screw. And after that, the locking head screw is put, which is bicortical, in hole 1. After we have removed the locking head, after we have removed the lag screw, and then the spacer from the D hole is removed and a monocortical locking head screw is passed. So this is the final correction. The flap which was raised is put into the gap to cover the osteotomy, and this is how it covers the osteotomy gap, and this promotes healing in this large area. The osteotomy hematoma is retained by applying a compression bandage for 8 minutes. This time is utilized to check the correction and the CR. Then the wound is closed with a overflow drain. In the first 24 hours, patient is given analgesics and cold compression and manual lymphatic drainage to decrease swelling. And we must continue to work on extension either by exercise or by CPM, whatever the facilities are available. Patient is allowed partial weight bearing with 10 to 20 kg weight. There is no restriction of range of movement because it's extra-articular osteotomy. There is no need of orthosis and X-ray control is taken at 2 in two planes. At 6 weeks, patient is allowed normal weight bearing and intensive muscle rehab is started. Weight training. Clinical evaluation is done at 6 weeks, 3 months, 6 months, and 1 year, and a implant can be removed at 1.5 to 2 years time. So the advantage of a biplanar medial open wedge osteotomy is it preserves the vitality of the proximal segment with minimal dissection. It is an inherently stable osteotomy, gradual opening with adequate medial release should be done. Compression of the lateral hinge makes it more stable, and this allows a function to have in the presence of a Tomofix angle stability. This is one patient who was operated 9 years back. His MPTA was 79 on the right side and 78 on the left side. There was no joint space seen, and this is at the 13 months when the joint space is formed. He was also operated on the other side a year later. His MPTA was reduced on the right side from 91 to 91 on the right and 90 on the left. His pain is reduced from 5 to 0.5 on the right side and 4 to 0 on the left side. His MPTA improved from 79 to 91 on the right and 78 to 90. Range of movement and motion was increased because of the control of pain. The flexion deformity of 10 degrees was corrected on the right and 5 degrees on the left. His knee score and knee functional score all improved and remained so after that. So this is the video. You must concentrate on the sound when you are walking up and down. This is the age of 69. The amount of blood which he has gives an idea how trained and comfortable he is. Me down. He could just squat on the floor. Without any problem. So any patient who has a tibia vera with knee pain on the medial side should be operated by medial compartment osteo for medial compartment osteoarthritis knee by medial open wedge high table osteotomy. We should not close our eyes to evidence, science, and the art, that's surgical skill, and need over the population to sit and squat on the floor for activity of daily living. Thank you for your attention. It is said, the one who works with his hand is a craftsman, the one who works with a mind is a scientist, the one who works with a heart is an artist, but the one who works with his hand, mind, and heart is a surgeon. Thank you for your attention. So now we can have the
I wish to congratulate both Mangal and Sanjay for putting forth what should be and what is the most basic form of high tibial osteotomy today, the simplest variety. Firstly, just to say a few words, there is no need to compliment Mangal because he's known all over India, because he's simplified high tibial osteotomy and made it possible for first timers and beginners to use a simple fixator and to develop the confidence to perform a high tibial osteotomy, not get worried about achieving the perfect alignment on the table, which is, which we all understand is not a very easy task, and to be able to do it simply in the outpatients department. The fixator is very simple. It is not cumbersome. It is not unwieldy. It allows the patients to sleep in bed with the leg resting on the bed. it gives the patient confidence because it's minimally invasive surgery. And due to the achievement of more or less very good alignment, it gives good and consistent results. So there's much to be complimented on this method of hemicalotasis, which allows many beginning surgeons to get on with it. At the same time, I would like to compliment Sanjai for highlighting the technique of medial opening wedge high tibial osteotomy using the Tomofix system. This is arguably and most understandably the widest used osteotomy today in the world. The literature that's present, if you read Kista and many of the other journals, especially the knee journals, 90% of the literature in the world today is devoted to medial opening wedge high tibial osteotomy, and for a good reason. Because just like Mangal's Fixator is, very easy to use and is reproducible by many surgeons, especially the beginning ones, the Tomofix system has only a few, devilish tricks up its sleeve. The instrumentation is beautiful. You can achieve correct results. You can get, the patient mobilized up and early. So it has taken away many of the disadvantages. And so I compliment both of you. Thank you for making these simple techniques and popularizing these techniques.
Thank you.
Dr. Thakkar, if you have to make your comments. Dr. Thakkar, you can unmute yourself and
Yes, sir.
if there are some questions or comments.
No, but actually, principally, I agree with Dr. Mangal Parihar, what he has said already, that it's he had shown us the two cases also of high tibial osteotomy, and in which there was a little overcorrection as more than it was expected. I face it very frequently in my practice doing closing wedge high tibial osteotomy. And as especially he stressed that this cosmetic appearance is not accepted by particularly young patients. Old people will accept the condition, but younger patients may feel that their limb is being D-shaped. And if both the limbs are in excessive valgus, then there is always, because of knock knee, it creates some problem in walking. So principally, from the beginning, I agree with Dr. Mangal that Fixator assisted is the best, because here we have a chance to reduce the overcorrection also, that either Tomofix or in closed wedge with internal fixation is not possible. So this is the biggest advantage. But somehow, particularly, I could not adapt this technique, because since I come in contact with him, before that also I was doing closed wedge. I was used to closed wedge. That's why I stick to it. In between, I did open wedge high tibial osteotomy also. Yeah, even absolutely, when it is absolutely indicated, I always do open wedge. That's my comments on high tibial osteotomy. Thank you.
Dr. Ravi Mittal.
Hello. Good evening, everybody.
Yeah.
I heard both the talks, and I compliment both the speakers for elucidating the salient features of the osteotomy by different methods. And especially, there are situations where one would like to change the implant and not use the internal fixation. Am I allowed to ask some doubts?
Yes.
Now,
You are encouraged.
Okay, thank you.
Ask doubts, and you are encouraged to criticize also.
Okay, sir. Thank you so much. If somebody has got a unilateral symptomatic varus deformity with osteoarthritis, and we correct by a valgus osteotomy, they're relieved of pain, but often they said this leg looks different from the other one. And at times it's difficult to explain to the patient. So in such a situation, have you faced such a situation and what do you do for that?
You see, if it is, I would put it this way, if it is unilaterally varus, then it must be short little bit. So once you correct this, it will either equalize or maybe little longer.
Yeah.
But the pain, which is the main concern,
Yeah.
is, and osteoarthritis is usually bilateral. So once you tackle both the knees, the limb then becomes normal. Or that time when the other limb is not needed to be operated or is not operated, then a shoe raise can be given.
Yes, I had to give shoe raise in one case because this operated knee limb was longer than the other side.
Yes.
Yes. And
The price of doing any osteotomy, even if it's closed wedge, it will be shorter, it's open wedge, it will be longer.
yes, sir.
That is.
Sir, Dr. Mangal has described osteotomy using fixator and then slow correction over it. My question is, can we do acute correction and put a tubular fixator? Is it okay?
No, because the Tomofix, they do acute correction,
Yes, sir.
and it relies on two things. One is the biplanar part of it.
Yes.
So that biplanar thing is in good contact. Even if you see a gap on the ascending wedge, the biplanar is in contact, and that is healing already. And second, even if that takes a little longer time, even if if it's partly healed, not fully healed, and it's going to take another a total of maybe 5 or 6 months to become solid.
Okay.
But the overall construct of partial healing plus the plate is stable enough for the patient to be symptom free. Now that will not happen with a fixator. So the fixator will tend to get loose over time. The patient is not going to tolerate the fixator for 5 months and 6 months. So therefore, I think both of these things should not be mixed up. Acute correction, I think you should have some form of internal implant, whether you're doing, whether you're doing open wedge, whether you're doing a closed wedge. The only situation where you can do acute correction with a fixator, I would say with an Ilizarov, and you do a dome correction, where you've got good stability and you expect that this is going to heal in 3.5 months, by which time then the fixator can be removed. But otherwise, combining the principle of Tomofix open wedge with a jugaad of external fixation, I think is not a good idea.
Okay. And if we don't leave the gap open, we put in some bone graft and then put a fixator, would it be acceptable?
Yes, I would not. I would say that's not acceptable, but that the issue of accuracy of correction again comes up, and a unilateral fixator.
No, biplanar tubular fixator.
Yeah, I mean, yes, theoretically it could be done, but personally, I would say there is no real. What would you say is the advantage of that over just a regular Tomofix?
No, in children,
because if you are going to open it and if you are going to put in graft, you need a reasonably big incision for that, right? So increase that incision a little more and take all the advantages of a good Tomofix plate. I mean, even if the Tomofix itself is costly, there are good Indian clones also available now in terms of the metallurgy and in terms of the biomechanics. So personally, I'm not so sure that there is a big advantage to using combining those two techniques.
okay. Sir, I heard your talk before and your opinion regarding the procedure, adding the procedure of arthroscopy during the osteotomy.
Yes.
Now, if you look at the arthroscopy literature, they're combining root repair of the medial meniscus with HTO. Now, is it a rational thought?
No.
Or, okay.
To me, it's not a rational thought, because if you look at it depends on what literature you look. There is, I forget the name. I think his name is NAG or something. It's a Korean name, NG or NAG. I forget exactly. NG, yeah.
Yeah.
So this paper looked at root tears which were treated by root repair and without root repair.
HTO with root repair.
HTO with root repair and without root repair.
Okay.
And then they went back and did a scopy again.
Yeah.
And they found 50% of the patients who were treated without root repair had healed just with the osteotomy.
Yes.
And functionally, there was no difference between the patients who had a repair and who didn't have a repair, or patients who were healed and patients who were not healed.
Okay.
My personal experience, and I'm sure Milind and Sanjay will also, I think, corroborate that we have seen n number of patients who come with the MRI report of degenerative root tear, and then we correct the alignment or whatever is the issue without doing a scopy or something like that. And those patients remain symptom free. The exception is a patient with an acute root repair, acute root tear. Patient has been completely fine. And then suddenly all of a day, one day he goes pop and feels the pain in the back of the knee. And this is a young patient without established osteoarthritis, but the patient has varus. Now that patient requires a root repair, and you may consider also doing an osteotomy to ensure that the root repair heals. But the run-of-the-mill 45, 50-year-old, medial compartment wear, and then you do when the patient comes with the MRI, you see a tear of the root, degenerative tear of the root. That really is not a candidate in my eyes for a root repair. Milind, Sanjay?
I agree. If it is not mechanically interfering, then probably it is not. But I have very little experience of doing arthroscopy per se, so I'm maybe not the right person.
No, so that's exactly what I'm saying. How many patients that you have done have and you have seen that the MRI shows root tear, and then those patients have come and complained back to you that, oh, I'm not well. That's the point. That is the root repair really required or not? I say it's not.
Yes, same here.
I agree with Mangal. I completely agree. I have two comments to make as a broader in the broader context. Firstly, is within a very few minutes of us talking about osteotomies, we are being invaded by these arthroscopy concepts, to which I just want to bring notice to. We get invaded. What happens to the root tear? What happens to meniscal tear? What happens to meniscal extrusion? So we have to distinguish between cause, something that is causing the pain. You have to be able to establish what is really causing the pain. And the MRI just shows something that is present. Is that the cause of the pain? Is that the main ingredient of the pain? This is something we need to understand. And we have been in our complex, because arthroscopy is so very much more popular than high tibial osteotomy. These people are thrusting all these concepts upon us. I agree with Mangal. There is really, see what happens to me. I'm not an arthroscopic surgeon, but I perform a patellofemoral retinacular release, which gives me a window to look into the medial side of the joint, also a window to look into the lateral side of the joint. I have frequently removed large loose bodies. I have removed a extruded meniscus or a bucket handle tear, or I have removed a discoid meniscus, which is very clearly visible. So, but a root repair per se, possibly overkill.
Okay. Can I ask someone another question?
One thing more. It's probably classically said arthroscopy is not indicated. The American Academy says arthroscopy in osteoarthritis has no role. So there must be some truth of not doing osteoarthritis.
Okay. Sir, when there is a deformity in tibia, proximal tibia and distal femur combined, And we try to achieve the correct alignment by doing a tibial osteotomy only. The slope of the joint tilts laterally. Now, sometime back, it was considered to be bad, and a distal femoral osteotomy was advocated along with HTO. But the recent literature says that the lateral downsloping joint line is not a issue, and it doesn't affect the outcome of the HTO. So how would you react to it?
It's true. I mean, before our knowledge of the importance of looking at femoral varus, we've done n number of cases where we have or even today, if the tibia, femur is 90, 91 and there's no lateral thrust, I may think about overcorrecting the tibia. And Milind, in fact, I think in the last talk that he gave, he talked very clearly about DFO and JLO and all of that at quite a length. My reasoning for doing the double osteotomy when I do it is that number one, it reduces the amount of correction I need to do in the tibia, because the more you are, and especially if you're doing it with some form of internal fixation, you get to open less of a wedge. But more importantly is when I'm doing this for younger patients, I know they will last for 15 years, maybe 20 years, but at some point they are likely to require a knee replacement. Now, if you are grossly overcorrected, then your cuts in the for a TKR also get affected. So that is one of the reasons I do it. Otherwise, what you say is right, that a varus femur and a valgus tibia is supposed to be a good combination which protects against shear and protects against further damage.
Okay.
Milind will have something to say about the JLO. I mean, his whole, I think half his talk last time was
Yes, I heard that talk.
On that, yeah.
If I may elaborate a little, this is really getting interesting because, love challenges, and doing the DFO properly was a challenge, and it took a few cases of the learning curve, but we did it. And after doing it, some realizations have dawned. One is, as Mangal was saying, that the varus JLO, where the medial side of the joint line is elevated and the lateral side is depressed, and you have overcorrected in the tibia, let's say by a few degrees or somewhat more. So the patient has a varus JLO. So what I think I failed to emphasize, because it was a long talk. So how does the patient compensate this? How does the patient compensate? You have corrected the tibia. Okay, the femur is 91, 92, but you haven't done an osteotomy. Sanjay's patient is there. He doesn't want 2 osteotomies. My patient is there. He doesn't have the money to pay for 2 high quality implants. And, we cannot do, we do it on the tibia. So we
and patient can't pay for 1 high quality surgeon doing 2 surgeries, surgical cost also.
So what happens? How does he compensate? It's very easy. He abducts the limb. So there are 2 issues here. How to measure the JLO? Number one, there is a mistake. There is a confusion in the nomenclature. So if you get the nomenclature right, and if you measure the JLO right, and the patient is in varus JLO because you have not touched the femur, even though it's 90, 92, 93, 94, etc. And so he's in a varus JLO. So how does he compensate? Think about it. It's dead easy. He abducts the limb by a few degrees, and that varus JLO comes to neutral.
Okay.
It's easy. That's the way they compensate for an osteoarthritic, gait. That's why they have a broad-based gait.
Yeah.
Waddling. Now it comes to the interesting part. When we are in the beginning phase of our learning curve with the DFO, I'll tell you what happens. The patient comes to us with a 92 degrees of femoral varus, and he's got some varus in the tibia, and we feel latest knowledge is that we have to perform a DFO. Now what happens? You take your oscillating saw blade, or your osteotomy thickness. The oscillating saw blade thickness is 1.5 millimeters.
Yes.
The osteotomy thickness is 1.5 millimeters. So the 2 cuts you have made for a closing wedge, they themselves are 3 millimeters. Now, very frequently you find they have now literature says that DFO, it should not be more than 7 degrees. So if it's a small femur, especially if the femur is a small person, the amount of wedge that you need to resect is less than 7 mm. By 3 mm to tumhare cuts mein hi ja raha. So it becomes very easy to overcorrect the femur. Then what happens? Then he goes into a true valgus JLO. So I showed a picture at the end of my talk, but then what happens? How does the patient compensate for a valgus JLO? That's the difficult part. He has to adduct the limb while walking, which is miserable. He's miserable. So if we are to err on the side of doing less by only doing the tibia for many reasons, it's not such a crime.
Okay. Now, in the Indian population, if we have a varus both in the tibia and the femur, the apex or the cora lies somewhere in the diaphysis, usually. So,
Not necessary. It can, it could be due to a bowed femur, but it could also be due to a varus, like the lady I showed. Her deformity was in the distal femur, but then I have other cases where they have a significant bow in the femur, which basically causes that. So it could be either.
So would you still do a distal femoral or a diaphyseal osteotomy and fix it?
No, if it's actually on the knee preservation group, I a few days after that discussion, I put up one where the lady had a clear bow. So yes. I did a distal femur. I put a distal femur nail and did an osteotomy at the apex, which is in the diaphysis, which then got it back to sort of normal. It was, I think, 89 or 90, which is inside the normal range. And then I did we corrected about 6 degrees or so of that bow. So unless you could correct it distally also, but if there's a large bow, personally, I would say, okay, it's, I can correct it well with this. But the small amounts, you cannot, with the diaphyseal, you cannot overcorrect.
Yes, you cannot.
With the metaphyseal, even if you say that, okay, the angle is 91 and I want to gain a little extra. So instead of going to 87, I will try and go to 85. That I can do only on the metaphyseal. That I can't do with the diaphyseal. Diaphyseal will give me only whatever the canal will allow.
Okay.
Which is usually 87, 88.
Okay. Sir, in the biplanar osteotomy that has been described classically for Tomofix, the vertical limb goes up towards the knee joint.
Yes.
And they say the requirement of the opening of wedge is more, you can do it inferiorly also.
Yes.
Now, would it be okay if as a routine, we do only an inferior cut, not the superior cut?
No, the inferior cut has got a lot of problems in terms of it's a very thin part. It's going into cortical area.
Yes.
There is a risk of breaking that because you're doing a large correction. And the way you have to fix that when you do a distal, you have to fix it with screws. So there is definitely a risk of fracture. Whereas the proximal is in, as Sanjay showed, is in metaphyseal bone that starts healing within about 3 weeks. That anterior-posterior healing is happening. So I will certainly not suggest that routinely we should do a distal osteotomy. It should be done in really cases where there is a problem in terms of correction.
Okay. Thank you very much, sir.
I have a question for Sanjay. Sanjay, what I have faced the problem with the Tomofix plating system. I am a very faithful adherent to the Tomofix, and I probably have done more than 150 in the tibia using the original Synthes Tomofix. The problem with the Tomofix is, firstly, there is no chirality. It's a standard plate for both the right and the left. That's number one. And in so doing, what they have done is when the plate sits very nicely on the upper tibia, what happens is that the screws, they face posterolaterally. And there is this indentation in the posterior part of the tibia in the center. If you're not careful, your screws can go into the very frequently because of the difference in the shape of the Indian patients. I wish I could pull up a diagram and show. I'll try and do that in a while if I can. But what I have to frequently do is I have to keep the plate offset from the bone. I have to keep it a little away from the bone, a little bit, so that my screws go more laterally rather than posterolaterally. Now, what that does is it gives me far better fixation. and it allows me a good night's sleep and very good stability of the fixation. But what it does is that the plate becomes a little proud and it starts irritating the patient. Now, this has happened to me a couple of times in the past, where this make the plate sit flush on the bone, and the screw, especially the posterior screw, it exits the tibia and it exits in that central zone in which the neurovascular structures are close by. And you only see it later in some x-rays. You may miss it. And I had to go down and back out the screw, in the sense, put in a new screw, lesser by 8 or 10 millimeters. So what is your experience? What do you feel about this? Have you come across this problem? You, Mangal, please.
When I put the plate, I put it more posterior.
Okay.
So if you put the plate more posterior, the screws are more lateral. If you put more anterior, then they go more posterior.
Okay. Okay. So the curvature of the tibia allows the screws to be placed to go more in the lateral direction than in the posterior.
Yes.
But then the same thing happens which you are talking of, that the plate, instead of sitting, along flush, it tends, because the anteromedial tibia is kind of angled, and then the plate will sit a little proud. But that is one of the recognized issues with the Tomofix, a prominent plate which requires removal.
I think
it
was
is an issue.
more often when the the generation plates were used, which were made for the Europeans, because the proximal part was.
No, that I agree, that is, you are talking of only the size of the plate. But what Milind is talking about, I don't know whether you're able to see, the tibia is like this, and then the plate, to get it lateral, you have to fix the plate a little bit like this, so that your screws go more medial lateral and not as posterior.
Yeah.
So yes, I mean, I had sort of, let us say, the privilege of assisting Staubli in a couple of cases in Mumbai. So I had that concept, and I am always very, very careful. So sometimes, even if I go through the posterior cortex a little bit, I will get a feel of it. So, and I'm sure this is the case with you also, that once you know about it, then it doesn't happen again. It happens a couple of times, but after that, it doesn't happen.
So I've taken the liberty of sharing this photograph, and this is the design. And to prevent the plate from the screws from exiting posterior, forget this. This is a TCV or osteotomy, but it's the same story with the MOW. This, I have to keep the plate, jutting out a little proud anterior.
Yes.
And that way I solve the problem. But that way the patient is slightly miserable. They do complain. And so there is an answer to this. There is an answer to this problem. And the answer has been found by the Japanese several years ago. They have plates for the right and the left. And the head part of the plate, the transverse part, is offset posteriorly. They have this. And I think it works really like a charm. Plus, you need to have the screw holes threaded in such a way that they face more anteriorly, or the head part of the plate is not only offset posteriorly,
Twisted
to face in the lateral direction. And that's one big peeve with the Tomofix system I have. I really, other than the fact that the machining is fabulous and the metallurgy and the elastic properties and the weight bearing ability is mind-blowingly good. But this thing is a bugbear that doesn't go away. Yes, Professor Mittal.
So I think the AO plate was designed to have the maximum purchase of bone in the tibia. And the way that they did it was by directing the screws posterolaterally. And in my initial days, I also made a mistake that my screws entered the tibiofibular joint, which was not visible on the AP X-ray, and the patient complained of pain. Can you hear me?
Yes.
So now I have realized that in the Indian patients, the North Indian patients that we get, putting a screw in the transverse part of the plate, not more than 50, solves the problem for me. And if we keep the plate away from the bone to change the direction in relation to the tibia proximal part, that makes the tibia very prominent, especially in the ladies.
Yeah.
and they start complaining of pain, which is even worse than the initial pain that they had before surgery. And we are in a dilemma that what to do with this. Now we can't remove the plate till it heals, and for 2 years it's a nightmare for everybody. So I think when we just keep the bone plate flush to the bone, that stops the irritation of the skin, and then and just imagine you want to drill the lateral cortex. Stop short of that. And if you take a view, a post-op view in the say oblique lateral view, you have to be sure that none of your screws are out of the cortex. And you can see only in the oblique view, not in the lateral view.
Correct.
But the way I understand is the whole A, B,
components.
C,
Practically.
and D all should have a monocortical screws.
Yes, sir.
So whatever the longest possible you can put monocortically should be used.
I know, but what happens is when you are trying to get the longest possible monocortical screw. Usme occasionally you go through the cortex, but if you keep what's the word? If you keep track of also, you realize, okay, that we've gone through the posterior cortex, and then you take a screw which is shorter. Yeah. So I don't think there's a big problem perforating the cortex, but it's not good to, in the post-op X-ray to see that the screw is behind, because then you're worried. But I'm sure Milind will agree with that this happens 2 times and 3 times at most.
Yes.
After that, then your senses are well aware of what can happen, and therefore then it doesn't happen again.
The
have a workaround.
The other method of not perforating the opposite cortex, which I've learned, is that you only drill the proximal cortex. Rest of it, you just push a little bit through the cancerous
No, there is that woodpecker sort of method.
Yes.
You drill and just drill and push
Yes.
till you reach the opposite cortex. So with
And
that works pretty well. I mean, and that technique works whether you're doing proximal tibia, you're doing distal radius, anywhere you don't want the screw to go through, you can use that. I don't know. I think it's called the woodpecker technique.
Yes, probably.
And
you also
post-op,
say-
sorry.
And you don't throw away the cancerous bone which gets into the drill bit. That's another advantage.
Interesting.
You just compress the cancerous bone into the hole.
Okay.
Okay. Interesting. So a couple of issues about the medial opening wedge. A couple of things that I still can't get my head around. So I would like to ask Sanjay personally, number one, and then Mangal, what is your approach to the release of the superficial medial collateral ligament? How do you deal with the release of the superficial medial collateral ligament? How exactly do you do it? How much do you do it?
I do it to the extent that the joint opens
Acutely, you mean?
on the table while you are.
Right. So you do it at the end of the surgery after you've opened up,
First thing,
or at
first
the
thing.
end, you do it the first thing.
Yes.
Right. So when you do it with the plate, Mangal, what is your take? What is your take on?
I slide a periosteum right down so that it is lengthened just like we do in a TKR.
Right.
Then I do that is mainly so that I can move it behind enough to
Right.
get my homons in without struggling. And then I'll do the open wedge, and I will feel the inside. And if I feel any tightness, I'll do a pie crusting. A couple of cases I have not hesitated to divide it completely when I was still finding it
That's
tight.
at the end of your opening wedge?
That is at the end. Yeah, that's at the end after I have put my plate in and stuff like that. Then the division. But pie crusting and all, if I'm finding it difficult to open, then I might do the pie crusting even earlier. And to the best of my knowledge, there are papers which say that not releasing the MCL can lead to paradoxically increased pressure on the medial side, and a complete release of the superficial MCL has no real consequence. In terms of it, you may think that it causes an increased laxity, but that is not so as far as the superficial MCL goes.
So actually, after so many years and so many years of doing these osteotomies on the upper tibia, I've come to the little harrowing and little disturbing conclusion that it is possibly not as innocuous as we think it is. And at the end of the surgery, if we release the superficial MCL a little too liberally, then we can end up getting a little more instability in the joint. And this is something that I'm working on, trying to the temptation to release it excessively has to be avoided. And one of the ways to permit the osteotomy, so the theory is that if you don't release it, then the pressure builds up inside the medial compartment. Yes, we know that. But what if we find other ways of allowing the joint to, the joint to open, like Sanjay was saying, without necessarily releasing a lot? So one answer is what Mangal says: you release it en masse, all the soft tissues en masse, with the pes and the superficial MCL all the way down to the periosteum, a little distally. And that way the integrity of the ligament remains, and some laxity and some opening is permitted without increasing the pressure. But I think releasing it a little liberally can have some deleterious consequences in the future. And especially if the patient has had a large JLCA to start with. That's,
yes. The other thing I think where it comes up is if you have, if somebody does not recognize a pagoda tibia, then the problem in that patient really was more of instability rather than the alignment. And if that part is not recognized, and then you try and correct it with more, changing the angle, then you are more likely to land up with trouble. But I think 9 times out of 10, that release and a little bit of pie crusting, if required, works. When it's very large corrections, only then.
Right. So
what is the advantage of pie crusting once you have released it?
Even after release, sometimes if you've done a large correction, you can't insert your finger between the plate and the MCL. It gets actually strangulated. By release, I'm talking of a distal release, not a transverse release.
The distal release is, you see, it gets attached at the 5 to 6 centimeters from the joint line.
Yes.
And as you retract the pes, you are in the bursa, and from there you can release it.
Distally, no?
Yes.
That's what I'm saying. So distal release will work, but if you're doing a large correction, then sometimes you need further, release of it. You've done the distal release, you've done the correction, and then you put the plate in, and then when I put my finger inside, the tendon is really stretched against my finger. Then I will do a pie crusting.
And you put the plate under the MCL or over it?
It is proximally it is under, and distally it is over. So proximally I am straight onto the bone, because I've put in my periosteum, I've put in my homons, and all of those structures are behind. Distally, I have the pes and the MCL.
The way I would understand is, if you raise the popliteus from the posterior border, then that will protect the neurovascular structures, and you can put the plate on MCL.
Yes, but
in fact, you should put
Sanjay, to get to the popliteus, you have to go anterior to the MCL, no? That means from the anterior edge
posterior
of the MCL.
to MCL.
Huh?
Posterior to MCL.
No, at least that's not the way that I do it. I go anterior to it, and that is why I need to release it distally so that I can take it behind.
Yes. I understand. Dr.
Ravi-
Mittal.
Ravi has something.
Sir, if we release the MCL from the distal fragment and not do anything to this attachment on the proximal fragment, I think
Yes.
we'll have no problem because your deep MCL intact, the
That's what.
superficial, that superficial MCL on the proximal fragment is intact. You just do the release on the distal side and not
Right.
on the proximal side.
You're right.
And then you will have no problem regarding MCL. I cut the MCL transversely at the upper border of PES and then release it subperiostally along with the PES when I'm doing a large deformity correction. And till now, I had no problems as far as MCL or the medial stability is concerned. It remains the same because the attachment on the proximal fragment, I don't touch it. I cut it transversely fully so that there is no continuity of the MCL between the proximal and the distal fragment, and release it from the distal fragment
And
later on also.
why you have the need to raise the PES?
Sir, because when we open it up, the PES becomes very tight. It doesn't allow opening and the adequate correction. When it is more than 10 to 12 millimeters, the PES becomes very, very tight.
Right. So this is very interesting, Professor Mittal, that you pointed out. So that brings to the other, if I may, with your permission and Mangal and Sanjay's permission, come to the next part of the doubts that fill our mind, and that even though most of the literature is on medial opening wedge, now slowly, if you look at all the new articles, they're finding a lot of problems that crop up if you are going to use the medial opening wedge high tibial osteotomy and perform large corrections. So, the thing is, we are not even talking about, let's say, we are not even talking about the instability and the pagoda tibia and all the stuff that I spoke about yesterday. Let's take an person who doesn't have those problems, but we perform a large correction, say 15, 16, 17 degrees, 18 degrees. Now, they are finding that there is, in many patients, it leads to excess pressure on the ACL. It leads to excessive pressure on the patellofemoral joint. Now, my question to Sanjay first, to Mangal, and to Professor Mittal is, do you agree in theory to this? Number one, have you come across these problems in your patients when you see them post-operative? Please, if I may have your inputs. Thank you.
I wouldn't exactly be able to say in very large corrections what would be the status would be. I think Mangal might have something to tell on that.
No, I have almost no experience, because the moment I see that there's going to be some trouble, I just go with a fixator. And if it's a really large correction, then I would not hesitate to use an Elizarov for that. So yes, but second thing is, mostly my osteotomies will be below the tuberosity. So these patellofemoral issues should not occur. I have not noticed anything when I do it with fixators, but that's because the osteotomy is distal to the tuberosity. So if I am in doubt, I will always prefer to go with a fixator, either a monolateral, or there are some of these patients, who got really bad varus knees. There I will not hesitate to use an Elizarov. Ultimately, it's less trouble as far as I'm concerned.
Yeah, great answer. Obviously, you have solved this issue about treating large deformities you're doing in the femur and tibia as well. You're using a fixator. So you're not facing this problem. You're basically not taking on this challenge of opening a large medial opening wedge with a Tomofix. But the thing is that
that is Abel Mujhe Maar.
No, but a lot of that's what young people should know. What do you feel, Sanjay, that suppose you open more than, Professor Stobley has gone on record to say that he has opened as much as 22 mm. Okay.
That is because of the plate does not allow you to open more than 22.
Yeah, but
This is what I showed you in the
yes, the distance between the D hole and the hole
one
number
hole is
one.
26.
Agree, agree.
And to have a maximum purchase, you can't go more than 22.
Yeah, but if we come to the problem that we are worried about, that when
Yes.
you open so much, what's going to happen to this so-called difficulties with, let's say, let's not even talk about knee joint line orientation. Let's talk about what happens to the patella. I have some experience. So first I want to know have you seen this? Have you experienced this? What do you feel?
Of course there will be, but I have no idea. I would say I have not applied my mind or seen something of that sort.
Okay, Professor Ravi, please.
Sir, if somebody has got a medial knee pain along with the anterior knee pain, I don't operate that patient with HTO. So I preoperatively, I look if there is any existing anterior knee pain, whatever the X-ray may be. So if there is existing anterior knee pain, I don't do HTO. And in my operated cases, the usual, because they come late to us, they don't come early to us, and it's very difficult to, when they are really problematic and it's disabling for them, they agree for surgery. And usually I end up opening around 15 millimeters. Until now, that problem is not there. Anterior knee pain is not there. Obviously, some people have complained of prominent hardware or incomplete relief of pain or whatever, but not the anterior knee pain.
So I like to, put the cat among the pigeons. This is, I don't know how many of you have seen this. Truth be told, I am finding that a vast majority of the patients who come demanding an HTO, in the sense that when they finally agree to do an HTO when they're really in pain, vast majority of them, I'd like to beg to point out specifically, I'm not talking anterior knee pain. I'm talking specifically patellofemoral joint tenderness, specifically on the medial side, specifically on the lateral side. I find now vast majority of the patients have patellofemoral joint line tenderness, especially when they have these large deformities. And I'm only talking about the medial opening wedge. I'll share an example with you. A lady, only 55. I only opened 9.5 or 10 mm of wedge. In her, I checked her twice, thrice, 4 times before surgery. She had 0 patellofemoral pain. So I took the classic oblique incision, just did the Tomofix. She did wonderfully well for some time. And lo and behold, what came and bit me, after 4.5 years, she comes into the chamber and she starts complaining of pain. And now I look at her, I think I opened about 10.5 to 11 mm or something, 11.5 mm if I'm recollecting right. And now she has come with patellofemoral pain. This I experienced many years ago. So even though I have this, as it is, many percentage of patients come with patellofemoral tenderness, and I do a release now without fail in each and every high tibial osteotomy. I am doing a patellofemoral release. I would like Mangal to tell me what his thoughts are on this, please. And Professor Ravi and Sanjay.
For academic purposes, I have been doing MRI. Okay. And in the MRI, I'm not only looking at the cartilage, but I'm also looking for the patellofemoral joint and the osteophytes. Right. And if there are significant osteophytes either on the patellofemoral joint or on the medial side or in the notch, I will open that and do what I call a debridement. Essentially, I excise all of the osteophytes. And that's what I was referring to in some of these patients. When there is a correction open wedge to be done, I will use those osteophytes into that gap. And those osteophytes have got a phenomenal osteogenic potential, because ultimately this is new bone that is being formed over there. So it's full of all those biochem stuff. So yes, I will always look for these particular things in all of the patients. And even if it's a relatively small correction that I'm doing with a fixator, I will add a debridement if there are significant osteophytes already.
And with
your voice, we don't have your voice.
And how often do you come across forget, I mean, yes, the MRI, yes, but actually clinically the patellofemoral tenderness. And on a lateral X-ray, how often do you see the osteophytes of patients who are willing to undergo surgery?
Meaning on the lateral, I will see the upper and lower osteophytes in practically every patient. That is there. So, and I will correlate it with the axial section.
Right.
And if there is a significant amount of osteophyte, I do not hesitate to open the joint and excise the osteophytes.
Percentage of your cases in which you do that?
I would say about at least about 15-20%, meaning 2 out of 10.
Okay.
And probably because my indications are also relatively extended.
Okay.
You know,
Okay. Thank you.
I don't believe in the classical indications and contraindications of a high tibial osteotomy.
Great.
When you done a open wedge, then the patella is shifted distally and laterally. So does it make any difference on the patellofemoral?
There are that I showed you that paper by Gasbeek who talked about opening wedge, creating increase in patellofemoral contact pressures and moving the contact laterally. So that is one of the, and that is why they talk about your biplanar wedge going distal instead of proximal when you're doing large corrections.
No, but by taking the tuberosity laterally, the medial side get decompressed or not?
Yes, but the lateral side gets compressed. There are papers which are looking at patellofemoral changes after a high tibial osteotomy, and they talk of an increase in patellofemoral changes, though they have not specifically pointed out in terms of patellofemoral pain.
Right.
But I think one of the things that we have to be careful about is the kind of corrections that we do is pretty large on an average compared to where they are doing it. We are tending to do it more for what we call a constitutional varus, and in the West with a well-aligned limb, only the medial compartment joint space reduction gives a certain amount of varus, and that they can correct. So that correction and some of the corrections that we do are pretty different.
Can I?
Yes.
I think one of the reasons for pain on the medial side could be hardware prominence.
No, but what Milind was talking about was
Patellofemoral.
medial patellofemoral
tenderness.
pain, not
Yes.
medial
See,
joint line pain.
I had 1 or 2 patients like that who had the plate prominence. They complained pain up till the distal thigh on the medial side and lower and the cuff also. And it was tender only in the say a medial retinaculum and the proximal tibia. So I think one of the reasons could be that.
One of the other reason could be irritation of that branch of the saphenous which goes from there.
Yes, but in that case we have a very pinpoint tenderness or something kind that, and say a trial of steroid injection in the subcutaneous plane can help. But when it's the hardware prominence, it's a nightmare. We just can't remove it also.
We've reached 8 o'clock, Sanjay.
Yeah, thank you so very much. It was very interesting and more learning for us. And I thank all of you.
Thank you, sir.
Rishi, thank you so very much. You can stop the recording.
And stop the streaming.
Right. But before he does that, I will share my screen and.
Okay. Thank you all.
Thank you.
Thank you.
Right. Thank you so very much.
Thank you.